Well, good evening and welcome. It is absolutely fantastic to have so many people here this evening on this NB Medical in collaboration with Cancer Research UK Hot Topics Clinic. It is just fab that so many people want to give up an hour of their precious Tuesday evening to join us to talk about this super interesting and super important topic. So, by way of introduction, let's start with that. My name is Kate Digby. If you have been on NB Medical courses over the last, goodness knows how many years, you may have seen me before, but I am a GP partner and trainer in the beautiful Cirencester in the South Cotswolds down in Gloucestershire. And when I'm not a GP partner and trainer, I'm a TPD for our local VTS scheme, bringing on the GPs of the future. I've been an NB medical presenter now for many years, doing lots of the different courses, but the cancer course is the one that really gets me fired up. So I am so pleased to be able to collaborate with Cancer Research and bring some of these free clinics to the foreground, just to give you a flavour of all the interesting stuff that's going on in the world of cancer medicine relevant to primary care. You will be really pleased to know that I am not the sole presenter this evening. I am joined by two fabulous co-presenters, and I just want to introduce them now so that you can see who's on with us this evening. So, by way of introduction, let's try the first one. And as I say, Sarah, are you there? And would you like to say hello?
I am here, Kate. Thank you very much. Very nice to be here. A very brief introduction from me. I am Professor of Health Policy and Practice at the University of Oxford. I haven't been an NB medical presenter for a number of years. I have instead a long history of researching the organisation of healthcare, including remotely. And through the pandemic, we've been really busy studying remote by default general practice and primary care. And I'm going to touch on that today. Thank you. Kate, back to you.
That is fabulous. Thank you, Sarah. We very much looking forward to hearing what you've got to say in a little while. Now, if you have done NB courses before, you will know we always have a wing person sitting there poised to answer all your questions and your comments that you may have this evening. So without further ado, let's see if Andy's there. Good evening, Andy. Would you like to say hello?
Okay, hi, Sarah. Hi, everyone else. I'm Andy. I'm a GP, and I've got a lot of interest in this topic tonight as I work as inclusion health. I work in a practice that looks after homeless people in the centre of Leicester. So I've seen lots of health inequalities, really, and seeing the effects it has on people. I also work at Leicester Medical School, where I teach communication skills and remote consultations, which also will be covered a little bit later on today. So lots of interest for me here today. I'm going to be the Q&A person. I'm going to be trying to answer your questions that you can post in the chat box there. You'll see it on the screen there. Anything you want to ask, pop it in there. We'll have little breaks as we go through the slides to go over those, and I'll try and answer them in real time as well. So just fire away. Is anything you're not sure about, or if you want to share some of your experience of patients or cases that you've seen also, we can put them in that and share those. But I know we haven't got much time, so I'm going to hand back to Kate to carry on.
That's fantastic. Thank you, Andy. Look, we are joined by some proper experts this evening, so please do get your questions and comments in so that we can join and share in all the great learning that's out there this evening. Right, we're going to talk about health inequalities, and we're specifically going to think about health inequalities when it comes to cancer care and cancer screening particularly. So what I thought we'd do to kick that off is just to think a little bit about what we mean, what's the definition of health inequality, and then we'll consider that in the context of sort of the wider challenge that we have within primary care and certainly sort of our early diagnosis in cancer. Sarah's got a great section to talk about the impact of remote consulting, so it'll be fascinating to see what she has to say about that. And then, having sort of set the scene, I suppose, about where we're at and what our current challenges are, we're going to have a little look at some strategies to address the health inequalities that exist in our current primary care system. And as part of that, we're really going to focus on bowel and cervical cancer screening, where we've got lots of evidence of where the challenges lie, but also lots of great resources and great tips and tricks to see if we can address some of those inequalities and level the playing field, so to speak. So that's what we're going to cover. It's jam-packed and we now have 55 minutes, so let's get started. We're going to start with a poll question just to liven you up at home and so that it doesn't feel like I'm just chatting to Sarah and Andy from my study. Perhaps you could find the poll section of your webinar screen and answer this for me. How many cancer cases in the UK each year do you think are attributable to socio-economic variation? Do you think it is more than 20,000? Do you think it's more than 30,000? Do you think it's more than 40,000? Or do you think it's more than 50,000? Just have a little think about that. Now, I have to say, whilst you're answering that poll, that whilst I can see people are answering it, which is great, there's lots of you on this evening to engage with, so that's fab that you are. I can't see what your answer is, so there is no right or wrong here. Nobody's going to call you out for answering the wrong answer. So please just tell me what you think, so that we can talk about the findings in a minute. That's fab. Despite the fact it's Tuesday evening, everybody is very quick off the mark. Let's have a little look and see what people think. So there you go. I guess it's a bit of an open-ended question, isn't it? And there is a vast range. But in fact, the front runner on that poll was the greater than 50,000. That's a massive chunk of patients, if you think about it, whose cancer cases are attributable to socio-economic variation. I am just going to leave that hanging for a second whilst I cover one more slide, and then we will come back to the answer, so you'll have to just wait with bated breath. In terms of that definition of what is health inequality, I think it's summed up really nicely in the unfair, systemic and avoidable differences in health between groups. Because because of health inequality, some people stand to suffer worse than others and have worse outcomes as a result. Now, health inequality isn't new. We hear it a lot more now than perhaps we did a few years ago. But the problem has been there for a long time. I think what we've discovered now, and certainly since the pandemic, is that there has always been health inequalities in existence, but the pandemic has almost blown that gulf wider. And what we now have is a real difference between outcomes for the most deprived compared to the least deprived groups. And that is why there is so much focus now on trying to address these inequalities to try and narrow that gulf and level the playing field once more. Now, thinking about health inequalities, of course, you could apply this to any part of medicine, but we're thinking about it in terms of the cancer pathway. And it's been shown in all the evidence that, in fact, inequalities exist throughout the entire pathway, from the prevention of cancer through to the uptake of screening, the early diagnosis, the treatment and subsequent survival of patients with cancer are all influenced by the inequalities that exist. Now, for those that thought that the answer to that poll was more than 50,000, actually, it's not quite as severe as that. Back in 2020, Cancer Research published this paper, the one that's shown on the slide here, and they estimated that more than 30,000 extra cases of cancer in the UK each year are attributable to socio-economic deprivation. And when you start to take a deeper dive into which groups of, what outcomes are we really talking about? And there's a whole stack of evidence out there now that shows people with higher levels of deprivation have a higher prevalence of risk factors for cancer in the first place, such as smoking or obesity. They're less aware of the symptoms of cancer, so they're less likely to present in the first place. But when they do, they often find there are more barriers to seeking help. We know that patients from higher levels of deprivation are less likely to take up the screening programs that exist in the UK, and they're consequently more likely to be diagnosed following an emergency presentation. Now, whilst you can't say that all emergency presentations are actually cancer at a later stage, we would much rather the outcomes are generally better if you can avoid that emergency presentation scenario. People with high levels of deprivation report worse experience of care and unfortunately, outcomes are worse overall. Another poll question for you now, this one's just a quick question, is which cancer do you think is most strongly linked to health inequality? Do you think it's lung cancer? Do you think it's breast cancer? Do you think it's prostate cancer? Or do you think it's bowel cancer? What do you think the answer to that is? Just whilst I take a sip of water. Give you a little bit longer to answer that. A diagnostic lag that is past 8 o'clock on a Tuesday evening. That's great. Let's have a little look and see what you all thought. There you go. So again, we have a clear winner here. 70% think it's lung cancer. 23 think it's bowel. Do you think it's breast? Perhaps 1 or 2 think it's prostate. So again, you're absolutely right. Lung cancer is indeed the cancer most strongly linked to health inequality, and I shall come back to that in just a second. Now, you may have, I'm sure many people have heard of the NHS long-term plan. This long-term plan was published by NHS England in 2019, setting out lots of different targets and goals for the NHS over the coming 10 years. And thinking a little bit about cancer for a second, the ambition or the aim set out in the long-term plan was that by 2028, the ambition was to make sure that 75% of all cancers were diagnosed at stages 1 or 2, by 2028. So that was the 10-year plan. That was on the back of the fact that back in 2018, actually 55% of cancers were being diagnosed at these earlier stages. Now, two things lots of things were subsequently published, but the two to concentrate on are firstly Cancer Research Waterfall infographic, which I think is a really good pictorial example of how we can try and achieve this 75% target. And alongside that, there was actually a really interesting modelling study published in the British Journal of Cancer in 2021. So let's just look at the two things for a second. I think that the point of the waterfall infographic was actually, there is no one thing that's going to move us up to that 75% target. It needs a collaborative approach across the whole cancer pathway. So, for example, improve screening uptake, encourage the public to present when they have symptoms. So really get our public health messaging on point. Improve the referral pathways that currently exist, and develop the rapid diagnostic centres and such like to really shorten that time to diagnosis and try and streamline the whole process. But what the modelling study sort of highlighted was, in fact, when you look at the socio-demographic variation in the stage at diagnosis, looking at the 10 most common cancers, advanced stage is more likely in older people and those living in more deprived areas. So underpinning this whole sort of different parts of the pathway that we can do something about is this need to eliminate the socio-demographic inequality and level that playing field. And the modelling study highlighted the fact that if the inequalities were addressed, 4% more people would be diagnosed at stages 1 to 2. So that would move us 4% closer to that 75% target, even before we've done anything to optimise screening and diagnosis and so forth. So it's really fascinating that it's a multifaceted challenge that we have to address these health inequalities. You're absolutely right. For those that said lung cancer was the cancer most strongly associated with inequality, absolutely. You can see from this graph, it far outstrips any other type of cancer. And just as an aside, when you look at that graph, it's interesting to note that breast, prostate, and melanoma are actually have lower rates of diagnosis in those more deprived groups. But that's because they're less likely to present for screening, they're less likely to present with symptoms, and they're less likely to go on holiday and end up with that UV radiation exposure that is associated with melanoma skin cancers. So whilst they may have fewer cases, not necessarily for the right reasons. When you look at smoking prevalence, then smoking prevalence, has a clear deprivation influence. So it's higher in those that work in manual jobs, in those who are unemployed and the homeless. Smoking is higher in the LGBTQ community, in more deprived areas. Men are more likely to smoke. Those with mental health conditions are more likely to smoke. Those that live in gypsy or traveller communities, those with few educational qualifications, and those with mixed ethnicity. So really, it's a really mixed bag of different groups that are more likely to smoke. And of course, whilst we know that smoking is strongly associated with lung cancer, smoking is terrible for all sorts of other reasons as well, not least the fact it is associated with 15 different types of cancer in total. So actually really addressing the smoking challenge is one of the ways of trying to reduce health inequalities. Now, you may have heard of sort of targeted lung health checks, but one of the major changes in the national screening recommendations for the UK last June was that the National Screening Committee now recommends the implementation of a national targeted screening programme for lung cancer. Now, it's targeted because it'll be aimed at all those people that would be invited would be those aged between 55 and 74 with a history of current or previous smoking. And the second bit of the recommendation from the NSC is that as part of this screening programme, smoking cessation needs to be integrated so that actually there's opportunistic time to really address the smoking issue. Now, depending on where you're based, if you're based in England, especially based in England in a relatively deprived area, you may already have experience with the targeted lung health checks that have been running for a few years. And these were set up in areas with high rates of lung cancer mortality. So whilst these lung health checks work reasonably well in terms of identifying some lung cancers, what we've seen in terms of uptake is that it actually is lower in those more deprived groups. So you could arguably say that those that really need to attend their screening are less likely to do so. And that mirrors what we see in other screening programs as well, because the uptake for bowel, breast and cervical cancer is lower in more deprived socioeconomic groups. Indeed, if you look at this table, this is just really summarising the groups that are less likely to attend for their regular screening invitations. So you can see from this, those in more deprived socioeconomic groups are less likely to attend. Those from ethnic minority groups or those that don't read or write in English as their first language, those with physical or learning disabilities, those with mental illness are less likely to attend. You can see the list goes on, and it's reasonably similar across all three of our national screening programs. But I suppose the exception that within cervical cancer, we have lower attendance from those who are part of the LGBTQ plus community. So when you're thinking about which groups in my area do I need to be thinking about, broadly speaking, these are the types of groups to be considering. Okay, well, that was by way of introduction. So before we move on to Sarah, let's hand over to Andy and let's see what you have to say about all of this. Andy, over to you.
Thanks, Kate. Yeah, good start. I mean, that 30,000 cases, I was reading through the cancer research booklet that comes with this course last night, and that's 80 new diagnoses per day. That's such a huge amount of people who have been affected by this deprivation, sadly. It's been really quiet on the Q&A, and as soon as we come to me, all the questions come piling in. This often happens. People asking about the targeted lung health checks. So that's people are between 55 and 74 who smoke or used to smoke, and they can be invited for a low-dose CT scan of their lungs looking for signs of cancer. That's what the lung checks would be. Someone here making the point, how are they identified for targeted lung health checks? Is it through the GP record? I don't actually know the answer to that. I will try and find out, and I'll read through the leaflets and I'll get that information back to you in the Q&A as we move on, as Sarah's talking there. And someone here, Helen's put, we have a screening program that's popped up in our area. Thankfully, I haven't had any lung cancer results yet, but loads of patients come in with letters that they have coronary calcification. So that's an unforeseen workload of worried, usually asymptomatic people. But I guess hopefully might be a good lever for them to think about stopping smoking as well. If they know they have that issue, it might be something you could perhaps use. And Patrick's answered my question. He says, yes, it is via the GP record. So thank you, Patrick. Really helpful. Saves me having to do a bit digging on that. I'm conscious we're a little bit short of time this evening. There's quite a lot to get through. So while you keep posting your questions, I'll try and answer as many as I can and share your points with the rest of the group. I'm going to hand over now to Sarah for the next part of the consultation.
Brilliant. Thanks, Andy. And thanks, Kate. So I'm Sarah Shaw. I'm going to talk to you about remote consulting and the intersection with health inequalities. So just very quickly, a bit of scene setting, just to talk about the expansion of remote consulting. I'm sure you're all familiar that there's been really a long history of consulting remotely in general practice, but that's largely been by telephone. That all changed during the pandemic, with remote services rapidly expanding across the NHS to manage the spread of COVID-19 and, of course, reduce the burden on health services. But that wasn't new. It was really just more a matter of scale and needing to rapidly scale up services, remote services. So the effect of that, patients who were seeking an appointment with their GP had to make contact by electronic form or by telephone, and before they were then getting a return call from a clinician. That's changed slightly as we've moved through the pandemic, but remote consulting has continued. It's varied. So there's a mix of telephone, a mix of video, and also e-consultations. Really worth noting that GPs, on the whole, rarely use video. So some of the current figures are that 2% of consultations in general practice in England are by video, and the rest through other medium. So before we carry on, I thought we'd just do a quick poll and just think about some of the practical things GPs can do to address health inequalities in the context of remote consulting. And so, do you want to use your poll pads and think about A, is it ensure your practice is providing patients with a choice of consultation? B, in remote consultations, actively inquire about non-specific but concerning symptoms, especially with patient groups who are less willing or able to come forward with information. C, develop knowledge about typical barriers certain patient groups experience along the pathway to help identify and support those patients. Or D, the short one, all of the above. I'll leave you to just answer that quickly while I have a sip of water. You can see the numbers going up. So A, B, C, or D. We'll just wait for a few more to come in. Brilliant. Overwhelming answer there. D, all of the above. So I think we're going to leave that hanging there and we're going to touch on some of these issues as we go through the next few slides. Thank you. So we've talked about the expanse of remote consulting during the pandemic. What's been the response? Well, generally, GPs have welcomed the infection control benefits that have come along with remote consulting. Empty waiting rooms, particularly early on in the pandemic, slackening of red tape that accompanied that initial shift to remote consulting. However, there were also concerns about loss of continuity of care, threats to the clinician-patient relationship, particularly about therapeutic presence, and inequalities of access and also clinical risks that were thought to go along with remote consulting. A couple of other things. I'm sure you're aware of media coverage, and early on, media coverage of remote consultations very much mirrored that pattern with a very initial positive response, but quickly followed by stories about inaccessibility, misdiagnoses, and patients being fobbed off with phone calls. And I think that kind of coverage has generally carried on through the pandemic. In terms of patients, well, patients have generally welcomed the choice of modality. So the ability to be part of a discussion and a decision-making process that might be about in-person or remote. However, they have also had some concerns generally about access for everyone, but particularly for certain groups. Before we get into the detail of that, I just want to think about the knock-on effects of the spread of remote, because it's happened quite quickly. So just to very quickly recap, there's been a knock-on effect on access to care, especially with patients who have difficulty getting the kind of appointment that they prefer or they wish for. There's been a knock-on effect on remote clinical assessment of patients, especially those with a really complex clinical picture, revolving symptoms, comorbidities, learning difficulties. There's been a knock-on effect on clinical risk management and safety netting, and that's particularly in relation to acutely unwell patients. So the example here is non-specific but concerning symptoms that perhaps don't warrant the 2-week wait. There's been a knock-on effect on continuity of care, and especially, I think, about creating coherence over time. So now we're talking about multiple modalities, remote and in person, thinking about how those fit together over time to ensure continuity. There's also been some concern or perhaps more awareness about patients' home and family context when thinking about remote consulting, notably concerns about privacy and safety, particularly with vulnerable patients or those who might be vulnerable to domestic abuse, and ensuring that they're safe from eavesdropping or coercion. There's also a knock-on effect on digital exclusion. So that's including the impact of poor quality technologies, issues of potential digital literacy, but also material aspects of the home environment. So that might just be something really simple in terms of access to the internet, but tricky for some, and even more so being homeless. And then finally, there's knock-on effects on vulnerable groups. Kate's already mentioned some of this, but impact, for instance, on people with drug dependency. So the reduced in-person pickups for controlled drugs has basically resulted in fewer opportunities for direct clinician-patient engagement, hence the knock-on effect. And I just wanted to flag some of the work that we've been doing in this programme of remote by default primary care. We've been talking to a number of GPs across England, Scotland and Wales. And this is just a quote from one of the GPs we've spoken to, and particularly picking up on those last 2 points about digital exclusion and vulnerable groups. And this is the kind of thing that we're hearing, particularly with the outreach population. It's just so easy to ignore them. You know, they're not jumping up and down, making a fuss, and they can't jump up and down and make a fuss because they can't fill the forms in, because they've got to have internet access to fill the form in to complain. So yeah, it's really quite insidious, really how it excludes people. So who then should GPs be concerned about? Well, I think Kate has already touched on some of this in her slides as well. But I think when it comes to talking about remote consulting, there aren't necessarily really hard and fast rules here. So some groups are definitely of more concern, but it's difficult to have universal rules to apply to everybody. I want to look here at the CR UK GP Omnibus Survey, which was last year, and just thinking about the patient groups that GPs were concerned about who maybe might not be contacting primary care compared to pre-pandemic levels. And you can see here the figures in the list, but particularly older adults, those with learning disabilities, those whose first language isn't English, those from an ethnic minority group, from lower socioeconomic backgrounds, and to a lesser extent, men. And I think that survey and those survey results, that reflects the wider research evidence base on access also, and resonates with some of the messages that Kate had as well. I just want to touch here on consultation type. So there's been quite a lot of discussion about how you make a decision about the modality of consultation. There's lots that we could say about that. I just wanted to pick up on one thing in particular, which is when telephone consultations might perhaps be more challenging than face-to-face when identifying cancer symptoms. And I'm going back here again to the CR UK Omnibus Survey, but this time from 2021. And these were the groups, perhaps unsurprising, that GP respondents said was more challenging by phone, particularly those with speech or hearing impediment, again, those whose first language isn't English, learning disability, and those over 75. So they're really kind of top of the list, but then also patients from an ethnic minority and again from lower socioeconomic groups. Worth noting here as well with that survey that fewer GPs reported challenges with video consultations compared to face-to-face, but perhaps unsurprising given what we said before, that GPs rarely use video. I just wanted to put up this as a summary slide, actually. So I've talked about rules of thumb, and there aren't necessarily universal rules here. And we've touched on issues down the middle of the slide about access, time, workload, confidentiality, technology, but also quality of care. We've begun to look at those. And this was just a summary slide, trying to get across that actually there are benefits and potential challenges for each of these, and it's just not clear cut. So if we take just one example in terms of workload, we've heard an awful lot in our programme of work about GPs not reporting an increase in workload necessarily and using remote consulting in productive ways to potentially manage demand. But we've heard completely the opposite as well in terms of increased workload, and that actually introducing remote consulting has perhaps opened in inverted commas, the floodgates in terms of managing demand. So there's lots of things to be aware of in relation to your own practice population and what to do with these benefits and challenges. Just turning here to digital exclusion and also issues of intersectionality or multiple disadvantage. I'm sure all of you are familiar with the inverse care law, that people with most need of healthcare are also least likely to receive it. And I think what we've seen with the increase in digital technology and its use in healthcare, increase in remote consulting, is that inverse care law is now being compounded by differential access to healthcare, depending on digital access, digital literacy, or both. And what we're beginning to talk about is really a digital divide here, but that needs to be considered not just in terms of kind of quite obvious things, in terms of internet access, but also in terms of bandwidth, data, skills, and also I think power. So for instance, who in a household has use of a computer or who has access to data? Now, some groups, like the neurotypical, are said to feel more comfortable with remote consultations than face-to-face consultations. However, I would just say that much of the evidence on that at the moment is anecdotal rather than kind of rigorous research on that topic. And then these final 2 points I just wanted to draw out about intersectionality. We're increasingly having a conversation about intersectionality or multiple disadvantage. So the existing evidence is showing that there's an important impact of different patient characteristics, but in combination, not just individually. So we need to address more attention to those inequalities as multiple disadvantage. So the example here will say gender plus age plus disability plus geography. I'm just wrapping up now just with some suggestions. So thinking about all the things that we've talked about so far, some suggestions for running remote services. First of all, work to ensure diversity of provision. Sounds quite obvious, but digital, but also non-digital alternatives to ensure that patients and the people supporting patients are able to select from a wide range of options to suit their particular access need and their preferences where you can. Where possible, co-design access pathways with patients. Be aware of groups at risk of not accessing healthcare and understand not only what the practice might do, but also with system partners, what you can do in your roles as individuals or as cancer leads to enable more equitable access. Reassure patients that primary care is open, not necessarily always the message they're getting at the moment. Ensure people's support needs and appointment preferences are recorded somewhere to allow appropriate appointment allocation in the future. And then work with external organisations to strengthen digital skills, particularly for vulnerable groups, and reduce digital exclusion. A few more here, suggestions just on doing remote consultations. Just to bear in mind that remote consultations, as I said, they're not one size fits all. Need to consider each patient individually when triaging, consider their presenting complaints, barriers to remote consultations, and then also this intersection of patient characteristics and how that shapes access. Reflect on evidence that suggests remote consultations are less effective for complex and unstable conditions or in diagnostic triage. And then when in remote consultations, perhaps actively inquire about non-specific or concerning symptoms with groups who are known to be less willing or able to come forward. So, for instance, some of the groups that we've talked about already with language barriers or lower health literacy. And I would add to all of that, bearing in mind capacity constraints, particularly at the moment, that limit the practices, but also system partners' abilities to undertake things like co-design work or to provide a really high degree of flexibility or indeed provide sufficient face-to-face slots to accommodate people's preferences. So I'm going to hand over in a minute. I'm just going to flash up some of the resources that you can also find on the resource tab. And then I'm going to pause there and hand over to Andy. Thank you.
Okay, I am here, don't worry. I just clicked the wrong button. Thanks, Sarah, really interesting. And so thinking about health inequalities around digital interactions and remote consultations, 7.6% of adults in the UK have never accessed the internet. And it's quite a lot of people if you think about it. Most of those are over 75 or economically inactive. So, they're the sort of people we're talking about here, definitely. People putting some comments here about older adults not using mobile technology, but having the old-fashioned landline that they're so familiar with, and actually as they're getting phased out or getting more expensive to maintain as lots of providers are trying to shift us onto mobile packages, they're going to be left out a little bit. And someone here who works in the countryside saying that if the power goes out, the mobile phones go down, so she's dreading the thought that landlines might eventually be phased out. I don't know if people are talking about how they use this sort of triage system, really bringing the patient in when they decide they need to see them, how that can be useful if you've actually done the initial part of the consultation. And I think continuity of care can be a real issue around remote consultations. And I think if you can build some continuity into it, it does make it work a little bit better. And people talk about ways that they've been able to achieve that. And I've posted some of those in the Q&As they've come through. And then the final point, someone's saying that if they do decide to go to face-to-face, it can be quite difficult trying to get working hours to match. And certainly people who are working in socially deprived areas, particularly maybe working shift systems, may have difficulties around childcare, and actually trying to get appointments in the daytime when they can actually get to the surgery can be really challenging for people like that. And so many people living in poverty now are actually working, not unemployed, so it can be really difficult for them, and trying to fit things around them can be a problem too. And certainly that's probably one of the things that is contributing to the health inequalities that we see. So good points coming in, lots of people sharing their experiences, and keep doing that, please, and I'll keep sharing them with the rest of the group. And I think it's time to go back to Kate just to the last part of this session.
Thank you very much, Andy, and thanks to Sarah. That was a really good insight. Lots of food for thought, I think, as I was listening to that. So we have set the scene now. Let's have a think about what strategies we can employ to help us address these health inequalities. Let's start with the kind of contractual stuff, or where we can find guidance. So, it's what we've talked about is sort of fairly general, observations of where health inequalities exist and which groups are particularly affected. But of course, if you and I want to make a difference to our local populations, we really need to know what's happening on the ground in our local area. And there are places that you can go to get that information. So just to flash them up, and these, of course, will be a little bit dependent upon where you live and work. So first up, for England, we've got the Office of Health Improvement and Disparities, OHID's fingertips data. And the fingertips data is a really good resource. You can drill down right to practice level, or you can go to PCN level, or you can go a bit higher to sort of ICB type level. Information on what is happening on the ground in your local area. If you work in Scotland, then NHS Scotland will provide you with similar information. Public Health Wales, or indeed HSC in Northern Ireland, are all in charge of sort of generating these bits of data in order for you to understand what is happening on the ground. And links to all of those websites you will find in the resources tab. Now, apologies to anyone not working in England, but of course for us who do work in England, we also have we also have targets to incentivise us to tackle health inequalities. And this year it's in the form of the PCN DES. So appreciating that this current DES is due to finish at the end of March, but we have had targets to look at health inequalities, looking at the urgent suspected cancer referral activity across our PCNs, and working really with our practice colleagues to share best practice, especially concentrating on those disadvantaged groups where early diagnosis rates are not as good. We've also had a separate indicator to get us to think about, improving bowel and cervical screening, cervical cancer screening uptake, really targeting the non-responders, and trying to engage with our local populations. So whilst these may change a bit for 23-24, we as yet don't have that information. So it's, hopefully everybody's been quite familiar with looking at these areas over the last 12 months. And just to sort of signpost you as much as anything to the Cancer Research GP Contract Hub. Again, the link is in the resource tab. This will be updated as soon as we know what our next DES requirements are, and that will be just a really good place to go to get the kind of distilled information, the need to know stuff, rather than read the entire document, which is always quite long. So what do we practically need to do? We need to identify our local population, and we need to consider what barriers may exist, bearing in mind that some of these barriers could be practical and some of them could be attitudinal. I think one of the things I certainly within my practice I have considered is whether or not all of my staff across the practice, from our care coordinators, our care navigators on reception, right the way through to our medical secretaries, and then of course the clinical staff, is to consider whether they are all equally aware of where health inequalities exist, and certainly for those that have direct patient contact. I spent a lot of time thinking about whether or not they are fully trained and comfortable in discussing the importance and the benefits of cancer screening when they are having those patient contacts. That making every contact count ethos when it comes to encouraging patients to attend. Now, if you think that's an area that could do with a bit of fine tuning or a bit of tweaking, then it lends itself really nicely to some multi-professional training, which suits it, which may suit you really well. What about language or cultural barriers? Because if you think about other sort of very obvious things, then that can be a real challenge. And then ask yourself, if you do think they exist, well, do your patients have access to the information and the advice that they need in accessible formats? And again, in the resources tab, we put links to all sorts of different resources that you can come back to and you can have a look at, take away the ones that you think would be most relevant to your populations, embed them in the offering that you offer your patients. Let's just think about bowel cancer for a few minutes, because the bowel cancer screening program uptake fell off in the pandemic, as you would imagine, because overnight everything ceased to function. Now, the really good news, certainly for England, is that bowel screening uptake has recovered beautifully, and it now actually exceeds pre-pandemic levels, which is great. Looking at data from England, it was up to 71% uptake in January to March of last year, which is really encouraging. One of the reasons that perhaps uptake has, bounced back so nicely is because we are now using fecal immunochemical testing as our screening test, and that's across the board throughout the UK. And that's generally felt to be easier to use by patients. One of the guaiac fecal occult blood tests, we're now using FIT screening throughout, and it's generally just a bit more user-friendly. Patients seem to get on with it better. So it's great that FIT has been adopted throughout the UK. One thing that has remained slightly different depending on where you live and work in the UK is the thresholds for which screening tests become positive. So if you happen to live and work in Wales or Northern Ireland, then the cutoff for a positive or an abnormal screening test is set at 150 micrograms of blood in a gram of stool. So it's 150 for Wales and Northern Ireland. It's only 80 if you happen to live and work in Scotland. And England have taken the middle ground, and it's currently set at 120. And when I say it's set, it's because these screening tests are put through a machine. They're put through an analyzer to determine if they're positive or negative. And of course, the machine can be fine-tuned to be set at different thresholds for churning out positive or negative results. So that's one difference in the screening programme, depending on where in the UK you work. The other difference is the age at which bowel screening starts, because that does vary throughout the UK as well. In Scotland, it has started from 50 for many years now. So anyone aged between 50 and 74 in Scotland are invited to bowel screening opportunities every 2 years. In Wales, the age is dropping down. So it was set at 60. It's now been dropped to start at 55. So in Wales, patients aged 55 to 74 are being offered bowel screening. In England, it is also dropping with the ambition of getting down to start at 50, the same as in Scotland. What you'll actually find over the course of the next few years is that patients in their 50s will be invited to start their bowel screening programme. And they'll be offered bowel screening every 2 years. So it's the age of starting is dropping down, and it's completely dependent upon how resources are set in England. Because of course, the more people you invite to screening, potentially the more abnormal screening results that you will have. That will put pressure on endoscopy services and secondary care services to follow up those positive screening results. So it's down to resources, but what we will see over the next few years is that England will start their bowel screening programme as well. The Cancer Research have put that together in quite a nice at-a-glance document, which you will find in the resources tab. Cancer Research carried out a survey in October 22, just thinking a little bit about sort of barriers to participation in the screening programme. And I asked the question, what would make you more likely to complete and return your FIT screening test for bowel cancer? And the top three responses to that question were a printed step-by-step guide on how to complete the FIT screening test, information about the importance of doing that test to be sent out with FitFit, and a letter from a GP reminding me to complete my FIT if I don't send it back. Now, those three things, actually, when you think about them, we can remedy all three of those relatively easily. Cancer Research have put together a really useful good practice guide for the bowel screening programme. Again, you will find this in your resources tab. But contained within this good practice guide is loads of information, including a sample GP endorsement letter you can send to patients, or sample text messaging wording, or even a phone script if you're going to have one of your staff phoning non-respondents and talking to them about why it's so important. Well, there's a sample phone script even for them to follow. There's lots of information about the bowel screening programme, some quality improvement suggestions for you, and even some screening contact information. All of that is in there. And there's also a link to a really good pictorial step-by-step guide on how to complete a FIT test. And that's the test that I send that to patients. I link it to a text message and I send that out to patients, even when I'm asking them to do a symptomatic FIT test as well. We have heard an awful lot about FIT, okay? It's the new investigation on the block. There is oodles of evidence coming out to support its use when we are evaluating patients with symptoms that may be caused by colorectal cancer. So this is where we have to be very clear in our messaging to patients, because the symptomatic FIT, or the QFIT test, as it's often called, the quantitative FIT test, is a different test to the screening FIT. It might look the same in terms of the way it's presented to patients, but the key difference is that the threshold for a positive result when it comes to a QFIT is much, much lower. It's typically set at 10. So I've told you already what the screening cut-offs are. They're much higher, 80 to 150. If you ask a symptomatic patient to do a QFIT for you in the practice, the cut-off for an abnormal result will be set at 10. And at this much lower level, it's a much more sensitive test. When we're trying to sort of identify patients that may have symptomatic colorectal cancer, we obviously want to use a test which is far more sensitive. And this is just a key difference to explain to patients, because otherwise patients erroneously think, well, I've done my screening test recently, I know I haven't got bowel cancer, therefore I don't need to repeat it to the doctor. And that's the key messaging that we need to get across to patients. So what we've seen, certainly since the pandemic, is, of course, that QFITs have now come online, and in many colorectal cancer referral pathways, we are now asked to either do one at the point that we refer, or indeed for some pathways, we need to have the results to make that referral. And that's, that has been a really positive change, and it's vastly increased the number of QFITs that are now being done. It's also formed part of the PCN-DES target indicator, really encouraging us to do a QFIT far more readily in patients with symptoms that could be colorectal cancer. So that's even vague abdominal pain, that we just need to be thinking about it. Now, this is a definite hot topic. I think QFITs are here to stay. What we saw last year was two key bits of key guidelines were published. One was a joint guideline published by the British Society of Gastroenterology, and the other was a piece of guidance from NHS Scotland, specifically giving recommendations on when a QFIT should be done in patients with symptoms in primary care. So these are just two of the key guidelines that were published last year. NHS, NICE is currently updating its recommendations. I expect we'll see that later this year. So I think QFITs are here to stay, and their role within the colorectal cancer pathway is likely to evolve further. Cancer Research have done a few other sort of interesting surveys with interesting results. One was this one published last year, and that asked, would you do a FIT if you had bowel symptoms and your GP or health professional asked you to do one? And 84% happily said yes, 62% said yes, definitely, just 22% thought probably they'd do one. But interestingly, the groups that were statistically significantly less likely to say definitely they would do one included men, those of a younger age, certainly between 18 and 34, those living in London, those from more socioeconomic deprived groups, and those of BAME ethnicity, especially Black and Asian people. So again, that's almost where our key messaging needs to be on point in order for us to really get that across to our patients if we are asking for them to do a FIT. Let's just turn our attention, before we go back to Andy, I can see the questions are flooding in, but before we go back to Andy, let's just think a little bit about cervical cancer screening, because unfortunately over the last 10 years, screening uptake has declined for cervical cancer, and it's lowest in groups that are youngest or oldest across the age range that are invited for cervical cancer screening. It's lower in those living in areas of high deprivation, again, ethnic minority communities, those with learning or physical disabilities, women who have sex with women, or even transgender people with a cervix. These are all the groups that are not attending for their cervical screening. When you look at the barriers to participation when it comes to coming for cervical screening, they vary, but the key responses that we see are those that are embarrassed or are worried that the procedure is going to be painful, those that worry about what the test might actually find, those that have had a previous negative experience, especially those that have been victims of assault or abuse in the past. There's practical elements that stop people from coming, such as difficulty accessing appointments at a time that suits, or finding the time to attend. These are the types of appointments you don't really want to bring your children in with you. So actually finding a time in the week when you can leave to somebody else and come to surgery for your cervical screening can actually logistically be quite difficult for some people. And then there's people that just don't fully understand why we do cervical screening or have any understanding of what the test entails. So again, we need to be mindful of how that works for people and what we can do to try and break down those barriers. We are now doing primary screening, again, in England, Wales, and Scotland. In Northern Ireland, they're still doing liquid-based cytology, but for the rest of the UK, we've switched to HPV primary screening. Now that means that whilst the end user experience of having cervical screening has not changed, what happens to those tests when they arrive at the lab is the first thing they get tested for is the presence of HPV infection. So if they don't have human papillomaviral infection, they are deemed to have a negative cervical screen and they're put back into recall. It's only those that have a positive infection result that then go on to have their liquid-based cytology. Now that means that what's changed in Scotland and Wales is there is now a 5-year interval between negative HPV primary screening cervical screens, which is great. That means that fewer people need to attend for their screening. In England, there is plans to move to 5-yearly screening, bearing in mind that the younger cohort of patients currently attend every 3 years. But again, we're just waiting for the National Screening Committee to implement all the sort of back office changes that need to happen in order to make sure the recalls work. So again, I think that that's something that we will see change in hopefully coming months, but certainly over the next couple of years. There's some evidence to support HPV self-sampling. That evidence is sort of evolving as we speak. But at the moment, there's been no mention from the National Screening Committee that those recommendations are sort of in the pipeline. Not such a far-fetched idea, though. If you think about our bowel screening program at the moment, that's an absolutely self-sampling approach. So whether or not in the future we start to see cervical screening being similar remains to be seen. But that might be one way to improving uptake because patients do not have to physically attend an appointment. Cancer Research have done another brilliant good practice guide for cervical screening, which contains pretty much the same sort of thing as the bowel screening good practice guide, including template letters, text messaging, wording, phone scripts, practical tips, and of course all the latest developments in the cervical screening program. So it is well worth having a little look at that as well. These are good practice guides I've had downloaded and frequently refer to when it comes to just making sure that my messaging is on point. The whole idea of sort of unifying our messaging is to try and minimise those barriers that exist and provide education and support whilst sort of proactively trying to identify and engage with those that aren't responding. Let me pause for breath there. Let's hand over to Andy. Let's see what Andy's got to say. Come on then, Andy, give us a rundown on all the comments and questions that I've seen coming in before we have to close for the night.
Yeah, thanks, Kate. Loads of people sharing really useful resources that they've used, lots of links. I'll put those all in the Q&A so you can quickly copy and paste them before the whole thing shuts down. If you don't manage to do that, you can come back to this webinar later. I'm sure Daniel will correct me if I'm wrong here, to access that and see the Q&A. So you'll be able to get the links. Lots of really good links. Some I've not heard of, some I've heard of. Joe's Trust I've heard of, but the Greater Manchester one I hadn't heard of, and I had a quick look, and it is really good. People talking about some of the barriers that they found in their own practice areas, some of the ideas that people have, and some of the, I've talked to my medical students about ideas, concerns, and expectations, and it really comes into reasons why people don't attend for screening. If you can find that out, you can often get people to go through the screening. Loads of questions flying in as we speak. Lots of people talking about different arrangements around fit testing. I don't know if everyone saw the BJGP this last week had an article about how it's important to get patients to understand why they're having the test, and they like it better from the GPs. Time is running out. I'm going to go back to Kate to wrap us up. Thank you for being so interactive. See you again.
Amazing. Thank you, Andy. I always feel these hours are just not quite long enough, are they? One very quick summary slide. Massive thanks to Andy and, of course, Sarah for giving up her time this evening and actually providing a really interesting insight into the impact of remote consulting. We clearly have an important role in trying to address some of these health inequalities in primary care because of the privileged position that we find ourselves in working within the communities that we do. And certainly when you start thinking about screening, I think that that the take-home message here is that, of course, NHS screening opportunities is an entirely individual choice, but idealistically, it is a choice that ought to be equally available to everybody. So trying to recognise those participation barriers is essential so that we can really, support patients accordingly. And hopefully, I've said resources tab enough times this evening to sort of signpost you to come back and have a look at all the resources that we've got in there, because we've really gone to town with making sure that there is oodles of stuff in there for you to have a little read of at your leisure. And that will hopefully just give you some signposting to things that you can help your patients with. So when I stop talking, which I promise will be in the next 30 seconds, the webinar will finish and there will be a feedback survey, which if we would be really grateful, Andy, Sarah and myself, if you could just spend 2 minutes filling that out. Just helps us design our webinars going forwards. If you love these free cancer clinics that we've been doing on a fairly regular basis, the next one that's coming up is actually with Action Bladder Cancer. We'll be talking about all things related to bladder cancer, so you might be surprised to learn. If you do fancy the free clinic in March, however, we are doing safeguarding then. So how many safeguarding hours have you logged? Do you need another one? There's a free one coming up in March. Otherwise, I am done. I am 1 minute over, for which I apologise. But I hope you've had a really interesting hour. I hope that you have learnt a few things. I hope it's going to make your life a little bit easier tomorrow. And I hope to see you again on the course very soon. Bye for now.